Dear student, I am Dr. 𝗠𝐿DL, Professor of Biochemistry. So in the lipoprotein metabolism lecture here, I will be going over LDL metabolism, lipoprotein little a and applied clinical aspects related with LDL and lipoprotein little a. Let's get into details. Now, as we have seen in our previous lecture in VLDL metabolism, so I have already explained to you that VLDL, it will be metabolized into IDL in the circulation. So VLDL is converted into IDL by the action of, this is just a recap of what I have done before. So, and IDL furthermore converted into LDL, and this will be done by CETP, which is continue to act, and hepatic lipase. Now the LDL that is made here in the circulation, which is rich in cholesterol ester, and this LDL, 40% of that, around 30 to 40% is taken up by the extra hepatic tissues, and 60 to 70% of circulating LDL is taken up by the hepatic tissue. Okay, so this is what briefly we have seen in our previous lecture, although a lot of details and diseases that I have explained in that. So just to know where we were. Now LDL is taken up by extra hepatic tissue from the circulation, that is 30 to 40% of LDL, and 60 to 70% of LDL is taken up by the hepatic tissue. So how this is taken up? So LDL will interact with what is called as LDL receptor, which is present over hepatic tissue and extrahepatic tissue. And this LDL receptor is a glycoprotein present over the cell membrane. Every tissue that needs cholesterol, it will express LDL receptor. So the expression of LDL receptor, it will be upregulated if there is a lower cholesterol inside the cell. Okay, you must remember that point there. If the cholesterol inside the cell is lower, so a lower cholesterol inside the cell means there will be increased expression of LDL receptor over the cell membrane, and it is a reciprocal relationship. On the other way, if there is increase in cholesterol inside the cell, then there will be decreased expression of LDL receptor over the cell membrane, because cholesterol itself is going to regulate the expression of LDL receptor in the cell over the cell membrane by acting at the gene level. Anyway, so LDL receptor, it has got 5 domain, and it is a domain number 1, which is referred as ligand binding domain, where ApoB100 is going to recognize this ligand binding domain. So ApoB100 is going to interact with the ligand binding domain. That is domain number 1. Domain number 2 is EGF precursor homology domain, and domain number 3 is O-linked sugar domain. Domain number 4 is membrane spanning domain, and domain number 5 is cytoplasmic domain. So these are the 5 domains that are present in LDL receptor. Now what are the functions of this domain? Like all this LDL receptor, which is divided into domain number 1, 2, 3, 4, 5. Domain number 1, as I already told you, it is going to interact with ApoB100 apolipoprotein, which is present over LDL molecule. Domain number 2, it is the sequence of amino acids in this domain is similar to epidermal growth factor. Okay, and domain number 3 is, that's where the sugar is attached to a LDL receptor, and that's why LDL receptor is a glycoprotein. Domain number 5 contains, it's a membrane spanning domain. It is rich in hydrophobic amino acid wherever it is spanning the membrane. And domain number 5 is a cytoplasmic domain, and this will interact with 𝐒𝐵𝐿. 𝐒𝐵𝐿 is a small molecular weight protein that will interact with the cytoplasmic domain, and thereby it is stabilizing that LDL receptor. Okay, so these are the divisions in an LDL receptor as domain number 1, 2, 3 and 4, 1, 2, 3, 4 and 5. Now here is the structure of LDL receptor, which what we have seen in the previous slide. So domain number 1, that's where ApoB100 LDL is going to interact here. So LDL, which contains ApoB100 over the surface, and this ApoB100 is the one that will recognize ligand binding domain and interact. So that's how LDL interacts with domain number 1. Now, EGF precursor homology domain, and then O linked sugar domain, as you see here, there is a carbohydrate attached here, and the membrane spanning domain, so where it is spanning the membrane, so this is where hydrophobic amino acids are predominantly present there, and the cytoplasmic domain, which is there in the cytoplasm, that's where clathrin will bind, and this clathrin is going to stabilize the LDL receptor whenever LDL binds to LDL receptor, and when the endocytosis goes on, so the receptor with the LDL will be stabilized with the help of clathrin. Now the receptor-mediated endocytosis process here. LDL binds to clathrin-coated LDL receptor. LDL is hydrolyzed by acid hydrolases in the endolysosome. Basically, when LDL binds to LDL receptor, so that along with the receptor, so the LDL is totally internalized. It enters into the cytoplasm where it will go and fuse with the lysosome to become endolysosome. Note that in this endolysosome, there will be pumping of protons into the endolysosome by ATPases. Lysosomal ATPases will pump protons into the lysosome to decrease the pH. So as the acid hydrolases are activated, so the LDL along with the receptors that are taken in, so they will undergo certain changes there. So what is the change here? Because of the acidity, so the LDL receptor along with the clathrin, which is binding with the LDL, right? So the receptor is separated from LDL molecule because there will be a hairpin loop conformational change that will be going on in response to the acidity. As the LDL receptor is internalized along with the LDL, so the LDL receptor will undergo hairpin loop conformational change because of the acidity, and that's why it will be separated from LDL in the endolysosome. So that means LDL is separated and the receptor is separated and the clathrins are separated. So the LDL receptor along with the clathrins, they will be recycled back to the membrane. Okay, so that means receptors and clathrin is recycled. So the LDL receptor has a lifespan of 20 hours. In 20 hours lifespan, LDL receptor will go back to the membrane every 5 minutes. Whether or not LDL is binding to LDL receptor, so in 20 hours lifespan, LDL receptor, it will go back to the membrane every 5 minutes. So that receptor recycling is going on continuously, making sure that LDL is taken into the cell from the circulation. So that receptor, LDL receptor maintenance is done in one way by hairpin loop conformation that is going on in the LDL receptor in response to the acidity that is present in the endolysosome. So hairpin loop conformation, let me write it down, hairpin loop conformation, and this hairpin loop conformation is because of acidity that is there in the lysosome, and that will help LDL receptor to go back to the membrane after separating from LDL. So what if this hairpin loop conformation do not happen? What if this hairpin loop conformation is kind of prevented? So what will happen? LDL is not separated from LDL receptor if that doesn't happen. That means LDL along with LDL receptor can be hydrolyzed by acid hydrolases that are present in the lysosome. That means receptor do not recycle back to the membrane. So the availability of receptor over the cell membrane simply decreases. So when the LDL receptor levels over the cell membrane decreases, that will lead to increase in LDL levels in the blood, and increase in LDL levels in the blood means LDL is rich in cholesterol. That's why it can lead to hypercholesterolemia. This is what happens if LDL receptors don't recycle back to the cell membrane. Okay, so already as I told you, the number of LDL receptors that are present over cell membrane, it is regulated by the amount of cholesterol that is present inside the cell. If there is more cholesterol inside the cell, there will be less LDL receptor over the cell membrane, because that cholesterol is not necessary for the cell, already plenty is there. Or if there is less cholesterol inside the cell, then there will be more LDL receptor over the membrane. So because depending on the needs of the cholesterol needs of the cell, LDL receptor number can be altered by regulating expression of LDL receptor gene inside the cell. Now, this is how LDL is internalized, and then LDL is undergoing a degradation to release its content inside the cell, and LDL receptor is recycled back. And I have explained you kind of briefly regulation of LDL receptor expression over the cell membrane. Now here in this figure is showing you exactly what I was explaining so far. So as you see here, LDL, which is binding with the LDL receptor with ApoB100, LDL receptor interacts with the ApoB100 and it is internalized, which is a clathrin coated there. And this clathrin coated receptor, as it is going and fusing with the lysosome to become endolysosome, and in the endolysosome, because of the acidic pH, so the hairpin loop conformation will be going on over LDL receptor, and it will be separated from LDL, and LDL receptor along with the clathrin will be going back, and it will be recycled back to the cell membrane. And the LDL is, the content of LDL is offloaded by the lysosomal enzymes. So ApoB100 is degraded into individual amino acids, fatty acids are released, cholesterol is released, and all the content, and including vitamin E released into the peripheral tissue. Now, the cholesterol inside the cell is converted into cholesterol ester. Cholesterol into cholesterol ester is done by enzyme acyl transferase. And now this acyl transferase enzyme is the enzyme that will store this cholesterol inside the cell as cholesterol ester, and that cholesterol ester, if it is necessary for cell membrane formation, that can also be used. And if there is an oversupply of cholesterol inside the cell, and that will have a negative effect on a cholesterol synthesizing enzyme called HMG-CoA reductase enzyme. And also the oversupply of cholesterol inside the cell, or if the cholesterol levels are high inside the cell, it will have a negative effect on the gene that is coding for LDL receptor, thereby LDL receptor expression over the cell membrane can be decreased. So depending on the levels of cholesterol, there can be alteration in the HMG-CoA reductase enzyme activity or expression of LDL receptor gene. And also cholesterol will have an effect on ACAT enzyme. If there is more cholesterol inside the cell, so that cholesterol will activate ACAT enzyme, thereby cholesterol can be converted to cholesterol ester and is stored there. Okay. Now this is how LDL is taken inside the cell, and it is getting in offloading its content for the cell. Now the thing is, one of the point that I was saying was that hairpin loop conformation, it helps LDL receptor to go back to the membrane. Now there are some molecules called PCSK9 molecules. These PCSK9 molecules, if they are present in the cell, if they are expressed in the cell, so what these PCSK9 molecules will do, they are going to go and interact with LDL receptor and do not allow hairpin loop conformation. That means PCSK9s will inhibit hairpin loop conformation in the LDL receptor. That means LDL receptor is not separated from LDL, so that means entire LDL receptor along with the LDL is degraded by lysosomal enzymes, because they both are not separated. And that's what PCSK9s will do. So presence or expression of PCSK9 in any person will lead to hypercholesterolemia. Why? Because PCSK9 molecules, what they will do is, they will inhibit hairpin loop conformation of LDL receptors, thereby they decrease the expression of LDL receptor over the cell membrane, because that receptor recycling is inhibited. So basically PCSK9 molecules inhibit receptor recycling over the cell membrane. So LDL receptor recycling over cell membrane. That's what PCSK9 molecules will do. Now let's move on to see PCSK9 inhibitor and the mechanism. So I told you in the previous slide, PCSK9 molecules, PCSK means it is a proprotein convertase subtilisin 𝐒𝐻G and type 9. These are the type of proteins, proprotein convertase subtilisin bar 𝐻G type 9 proteins. They are called as PCSK9 proteins, which are affecting LDL receptor recycling process. Whenever a person is expressing this PCSK9 proteins, so they are going to decrease the LDL receptors recycling process. Okay, so thereby when LDL receptor levels are decreased over the surface, so that will lead to decrease in the uptake of LDLs from the circulation. So the LDLs will stay back in the circulation, and that causes hypercholesterolemia. Okay, because what PCSK9s will do, they will inhibit that hairpin loop conformation in the LDL receptor and allow that LDL along with the LDL receptor to be degraded by lysosomal enzymes. Now how to avoid this? In a person who is expressing PCSK9 molecules, so there is a class of drug called PCSK9 inhibitors. These PCSK9 inhibitors, what they will do is, they are going to block these PCSK9 molecules, thereby they will allow recycling of LDL receptors so that LDLs can be cleared from the circulation and thus lowering blood LDL levels. And what are PCSK9 inhibitors? PCSK9 inhibitors, example given here is Atherosclerosis and 𝗑𝐻𝐴. Atherosclerosis and 𝗑𝐻𝐴 are referred as PCSK9 inhibitors, and these molecules, they will make sure that LDL receptors are recycled back to the membrane, thereby circulating LDL is taken in. So this is what is the role of PCSK9s and PCSK9 inhibitors in maintaining LDL receptor levels over the cell membrane. Now let's move on to see, understand the mechanism of atherosclerosis. Now note that atherosclerosis will be going on in the blood vessel, and the process of atherosclerosis, it is induced by availability of excess levels of oxidized LDLs. You've got to understand. Now the atherosclerosis, it is initiated by the presence of oxidized LDLs. Let's understand how that happens. Now whenever a person has got high levels of LDL in the circulation, basically a person having hypercholesterolemia, whether it is a familial hypercholesterolemia or it is a hypercholesterolemia secondary to some diseases like diabetes mellitus. So when there is excess levels of LDLs in the circulation, and along with that, if the person has got higher levels of reactive oxygen molecules, basically the oxidants, compared to antioxidants. So when there is an imbalance between the oxidants and antioxidants, oxidants are written on the left hand side here, that is superoxide, nitric oxide, hydrogen peroxide and other oxidants. When they are more than the antioxidants which are written on the right side, it is vitamin E, ascorbic acid, beta, carotene, glutathione, all this kind of antioxidants. So when there is an imbalance between oxidants are more and antioxidants are less, at that time what will happen? So LDL will be undergoing oxidation to become oxidized LDL. Now the oxidized LDL, it is an unstable molecule. That means this oxidized LDL can induce a cellular damage. As you see here, down here, concentrate on in the blood vessel where I am marking. So let me just box it. So this one. Okay, so we are here in the blood vessel, lumen of the blood vessel. As you see in the lumen of blood vessel, so presence of oxidized LDL in the lumen of the blood vessel. So it is going to cause injury to endothelial membrane, because oxidized LDL, it is a unstable molecule, so it is going to cause injury to endothelial membrane, and thereby it gain access into the subintimal space. So as it gain access into the subintimal space, so these oxidized LDLs will be followed by neutrophils, monocytes and macrophages. As neutrophils, monocytes and macrophages gaining access into the subintimal space, so they are trying to engulf these oxidized LDLs that are present there. So how these monocytes, macrophages, neutrophils, they are going to engulf oxidized LDLs? See, these monocytes, macrophages, neutrophils, all of them, they all express a special type of LDL receptors called scavenger receptors. Scavenger. The scavenger receptor, it is a low affinity, non-specific receptor. So as it is written here, low affinity, non-specific, non-regulated scavenger receptor. So what they will do is, they will continuously uptake oxidized LDL molecules, and thereby they will fill up with them with all the oxidized LDL molecules inside, right? So they will take up as much oxidized LDL molecules as possible, because they are non-specific and non-regulated receptor. So the levels of cholesterol inside them do not regulate the LDL receptor, receptor expression over the cell, unlike normal LDL receptor. Because as you see here, normal LDL receptors, they are high affinity, but they are down-regulated receptor. They respond to the levels of cholesterol inside. Whereas these receptors, scavenger receptors, they don't respond to the levels of cholesterol inside the cell. They are always expressed. That means they go on taking up LDL, oxidized LDLs in the subintimal space, just beneath the endothelium. So because of this, what will happen? So because of the continued uptake of oxidized LDLs by these monocytes and macrophages, so there will be accumulation of all these lipid-rich monocytes and macrophages, and we refer them as foam cells, because there a lot of fat is present there, lot of cholesterol is present inside the cell. Now it looks like a foam when it is observed under microscope, referred as foam cells. So what these foam cells do? So foam cells, these are the reactive cells. So what they will do is, they will release interleukins and cytokines. Thereby these interleukins and cytokines, they are going to, and growth factors, they are going to bring smooth muscles from muscle cells from tunica media, as it is shown here. From tunica media, smooth muscle cells are coming into the subintimal space, and they also start engulfing oxidized LDL, because they also express scavenger receptors. So they also become foam cells. Like even smooth muscle cells migrating into the subintimal space, they also become foam cells. Like this, more and more foam cells will start to build up beneath the subintimal space, and that leads to bulging of the subintimal space into the lumen of the blood vessel. So let me show you that. So it will be something like this. A fatty streak will accumulate inside the subintimal space. So this is all fatty streak that is accumulated inside the subintimal space, and thereby it is bulging into the lumen. So I'm drawing the endothelium here. So this is the lumen of the blood vessel, and as you see, the fatty streak, it has simply bulged. This is the fatty streak, and this fatty streak, fatty, F-A-T-T-Y, fatty streak. This fatty streak is basically a collection of all the foam cells which is bulging it inside. So because of this, what will happen? So the blood that is flowing through this small little space that is available now, so there will be increase in the pressure, increase in blood pressure here, and because of the increase in the blood pressure over the cap here, so this cap can break open. It can break open, and there may be injury to this, and it can totally fill up this gap, and that will occlude the vessel. So it's a complete occlusion of the vessel, or even the fatty streak itself can totally fill up as it grows. Okay, so thereby that particular artery can totally be blocked. So that like this, atherosclerosis is initiated because of the presence of increased levels of oxidized LDL. So make sure you remember that. So the oxidized LDLs will initiate atherosclerosis process. So that's why it is important for us to maintain normal levels of LDL and also to maintain good antioxidant levels and try to reduce the stress. Thereby we decrease the levels of reactive oxygen molecules or the oxidants. Thereby atherosclerosis can be prevented. Now when it comes to LDL receptors, gene for LDL receptor, so there can be a number of mutations that can be seen in LDL receptor gene. So as you know, LDL receptor, we have ligand binding domain, EGF precursor homology domain, O-linked sugar domain, membrane spanning domain and cytoplasmic domain. In each of these domains, so there can be a mutation in specific exons. Like in ligand binding domain, as you see, exon number 4, these numbers are exons, exon number 4 here especially. Look at the number of mutation in ligand binding domain and exon number 4. So highest number of mutations is seen in ligand binding domain, and exon number 4. Make sure you remember that. That's what is the frequency of mutation there. Otherwise also there can be a mutation in different domains of LDL receptor. Now let's get into familial hypercholesterolemia. What causes familial hypercholesterolemia? Familial hypercholesterolemia is because of mutation in gene coding for LDL receptor. Now the LDL receptor gene mutation leading to familial hypercholesterolemia follows autosomal codominant inheritance pattern. Now out of two alleles that are coding for LDL receptor, if one allele is mutated, it will give rise to a disease manifestation, although not severe as when two alleles are mutated, because when two alleles are mutated, it will give rise to much more severe disorder. So that means heterozygote presentation and the homozygote presentation. The homozygotes being much more affected than heterozygotes. And this is what is referred as gene dose effect that is seen in familial hypercholesterolemia. Now in familial hypercholesterolemia, LDL levels can be more than 500 milligram per deciliter, which can go as high as 1000 milligram deciliter. In order to get an idea, like about 500 and 1000, normal LDL is less than 100. Remember that. Normal LDL levels in the blood is less than 100 milligram per deciliter, whereas in familial hypercholesterolemia it can go more than 500 and it can be as high as 1000 milligram per deciliter. Now let's look at homozygous familial hypercholesterolemia. Homozygous familial hypercholesterolemia is because of mutation in both the alleles which are coding for LDL receptor gene. So that means useful LDL receptors will be, availability of useful LDL receptors are very less. So less than 2% of normal LDL receptor activity can be seen in some people with homozygous familial hypercholesterolemia, and that type of patients we refer them as receptor negative homozygote cases of familial hypercholesterolemia. If the receptor levels are between 2 to 25% of normal receptor activity, that type of patients we classify them into receptor defective familial hypercholesterolemia. So there is receptor negative and receptor defective. In the receptor negative, it is less than 2% of normal LDL receptor activity is retained. In receptor defective, it is 2 to 25% of normal LDL receptor activity is retained. And also, since it is running in the family, familial hypercholesterolemia, it is an autosomal codominant disorder. So, there will be positive family history of premature coronary artery disease running in the family. So, that positive family history will help in the diagnosis of familial hypercholesterolemia. Remember that. And also, the disease presents in childhood with cutaneous and tendon xanthomas and corneal arcus. That means a fatty material accumulated around the cornea is referred as corneal arcus, and accumulation of fatty material beneath the skin as a bumps which are smooth to touch with the fatty material there. So cutaneous xanthomas and around over the tendon xanthomas can be seen here. And one of the things that we see here in familial hypercholesterolemia is accelerated atherosclerosis, which develops in the first decade of life, and also it is around the aortic root. First it appears in the aortic root, and also before 2 decades of life it may lead to death. So basically symptomatic manifestation can start as early as first decade to second decade of life, and death can happen because of coronary artery atherosclerosis and also which begins in the aortic root. Symptomatic coronary atherosclerosis occurs before puberty. Sudden death is common, and for these patients, aggressive pharmacological therapy and liver transplantation helps in decreasing LDL levels, thereby preventing a development of atherosclerosis. That's about homozygous familial hypercholesterolemia. Now coming to heterozygous familial hypercholesterolemia. It is the most common single gene disorder. Again, positive family history is present. The disease is often not detected until adulthood. That means compared to homozygous condition, this is less severe. Age of onset can be highly variable. Corneal arcus, cutaneous and tendon xanthomas are seen, and again aggressive pharmacological therapy will help to decrease development of coronary artery diseases. So that's about heterozygous familial hypercholesterolemia. Coming to next disease, that is called as cytosterolemia. Now the cytosterolemia, it is an autosomal recessive mutation in a protein called ATP binding cassette transporter G5 and G8. That is ABC, G5 and G8 transporter. What is the role of ABC, G5 and G8 transporter? We must understand that first, then we can understand what is the mechanism of cytosterolemia. So, ABC, G5 and G8 transporters, they are important in the transport of plant sterols and cholesterol molecules. So, plant sterols, example, we have cytosterol and campesterol. These plant sterols we don't want in our body. They should not be part of our cell membrane. And basically what happens when we consume plant oils or the derivatives of the plants, like maybe a consumption of vegetables containing plant oils and all that. So however, so the vegetarian thing, so where the plant sterols will get into our diet, and these plant sterols generally not absorbed. 95% of the plant sterols are not absorbed in the intestinal lumen entering into the enterocytes. Only 5% of plant sterols are absorbed and they enter into the enterocytes. And from the enterocytes, only 5% is entering plant sterols. Let it as plant sterol, which is a cytosterol. Example for plant sterol is cytosterol entering into the enterocytes, and out of that, majority is pumped out into the lumen. So this is the lumen of enterocytes. I will make it as a brush border epithelium here. Only 5% of plant sterols are absorbed. So in that, most of it is pumped back into the lumen. That is through ABC, G5 and G8 transporter. G5 and G8 transporters, they are going to pump plant sterols back into the lumen of blood vessel. That's the role of ABC, G5 and G8 transporter. Basically, having G5 and G8 transporters over the intestinal membrane will decrease appearance of plant sterol into our body, especially into the blood, right? So, but still some amount of plant sterols will gain into our body through chylomicrons, and chylomicrons will go and offload that plant sterol in the form of chylomicron remnant, so into the liver. So they will find their way into the liver. Some of the plant sterols will find their way into the liver. I'm going to connect that to the liver now. So plant sterols are taken up by the liver there. So plant sterols are there in liver. Now these plant sterols from the liver, they will be pumped back into the biliary canaliculi. Biliary canaliculi. That means bile. And that is done by, again, ABCG5 and G8 transporter. And like this, because of the action of ABCG5 and G8 transporters, so our body generally don't contain cetosterol and camposterols in the blood or in the cell membrane. Okay, that is because ABCG5 and G8 transporters will make sure they will pump out that plant sterol back into the lumen, in the intestine and also in the liver. So this is what is the normal function of G5 and G8 transporter. Now let's get into the abnormality. So the abnormality here is whenever there is a mutation in this ABCG5 and G8 transporter, I'm going to block it now. ABCG5 transporter not working in the liver, intestine, it is not working in the liver. So what will happen? So the plant sterol gain access into the enterocyte, even if it is 5%. And then plant sterol gain access to the liver. From the liver, it will become part of VLDL. VLDL taken to the circulation, converted to IDL, IDL to LDL. LDL gets into the tissue, and that's how plant sterols will get into the tissue. So like this, there will be increase in the level of cetosterol in the blood, because it is part of VLDL, IDL, LDL. So increase in the levels of cetosterol in the blood, along with increase in cholesterol, because whenever there is a defect in the trafficking of cetosterol, this will also lead to defect in the trafficking of cholesterol. So cholesterol will also rise. So like this, there will be rise in plant sterol along with the cholesterol molecule. That's why individuals with in normal individuals, when less than 5% of dietary plant sterols are absorbed from the intestine, these plant sterols in the plasma and tissue are normally very low. But in cytosterolemia, so this, because of the defect, there will be increased in the plasma level of plasma and tissue levels of cytosterol and other plant sterols. Okay, so and there will be defect in the trafficking of cholesterol, which is also impaired, leading to elevation of plasma LDL cholesterol and elevation of plant sterol like phytosterol. Example, we have cytosterol and camposterol. So because of this, the signs and symptoms that we see here in cytosterolemia case is similar to what we see in familial hypercholesterolemia, that is xanthomas are seen, premature atherosclerosis is seen, and it can also lead to coronary artery disease and death. Very similar to familial hypercholesterolemia. Along with that, so patient with cytosterolemia will also show hemolysis, and this hemolysis is because of incorporation of plant sterols into the RBC cell membrane, which is an abnormal type of sterol, so it can lead to breakage of red blood cell membrane, leading to hemolysis. So familial hypercholesterolemia signs and symptoms plus hemolysis, that is RBC lysis, leading to increase in bilirubin and jaundice, and that is a clue for cytosterolemia. So in cytosterolemia, there will be increase in the blood levels of cytosterol. That's first thing. Second thing is there will be increase in cholesterol levels in the blood, and the third is signs of hypercholesterolemia. Signs of hypercholesterolemia can be xanthomas, different types of xanthoma, especially cutaneous and tendon xanthomas, atherosclerosis signs like increase in blood pressure, coronary artery disease, all that, and along with that, most importantly, so increase in bilirubin and presence of jaundice. So if all these things are there, it is a diagnosis for cytosterolemia, and the answer is defect in ABCG5 and ABCG8 transporter. Now let's move on to see a special molecule which is a lipoprotein called lipoprotein a. What is lipoprotein a, or simply referred as LPA? Lipoprotein a, structurally it is similar to LDL, because apo this is a apolipoprotein which is synthesized in the liver, and it will be attached to ApoB100 by a disulfide linkage, and there is a single disulfide linkage, as you see here, between apo-A and ApoB100. And of course ApoB100 is present over LDL molecule, and apo-A is attached to that LDL. So the structure is shown here for lipoprotein A. It is the LDL plus apo-A. So LDL plus apo-A is actually LPA or lipoprotein A. Now what is the physiological significance of this lipoprotein A? Why lipoprotein A is synthesized in the liver? So the physiological function of lipoprotein A, it is still not known. Or the major site of clearance of lipoprotein A is the liver, but the uptake pathway is also not known. So there are so many things that is not clear with lipoprotein A. What is clear is the structure of lipoprotein A. It is similar to plasminogen and tissue plasminogen activator. Now this, because of the structural similarity of apo-A, especially the apo-A component of lipoprotein A, which has similarity for plasminogen and tissue plasminogen activator, so it is going to compete with plasminogen for its substrate, leading to reduced fibrinolysis. Because plasminogen, when it is activated, it is converted into plasmin, and this plasmin, it is participating in clot lysis, which is called as fibrinolysis or the clot lysis. When the blood clot is formed, that clot lysis is done by, the process is called as fibrinolysis, which is mediated by a plasmin. Plasmin is an activated form of plasminogen. Now apo-A is going to compete with that plasminogen and tissue plasminogen activator, thereby it is going to decrease clot lysis or fibrinolysis. And also note that apart from that, so lipoprotein A also stimulates secretion of plasminogen activator inhibitor. That means this particular molecule is going to inhibit activation of plasminogen, and that leads to thrombogenesis, because clot is not allowed to be lysed. So thrombus continues and thrombogenesis, which can lead to cardiovascular events and cerebrovascular events. That's why the presence of lipoprotein A, it is an independent risk factor for cardiovascular diseases. That is what is the applied thing related with lipoprotein A. So the lipoprotein A, it is an independent risk factor for cardiovascular disease, because it is going to decrease fibrinolysis and increase thrombosis or thrombogenesis. Okay, so that is about LDL and how LDL is taken up by the cell, details about LDL receptors, details about atherosclerosis, mechanism of atherosclerosis, and familial hypercholesterolemia, cytosterolemia, and clinical application, and details about lipoprotein A or LPA. So that's about it. I hope this video has helped you in understanding this very important concept. Thank you.